Hello, hi. My name is Dr. Imran Khawaja, and I'm a psychiatrist and also a sleep medicine physician. I will be talking about obstructive sleep apnea and what healthcare providers, especially mental health care providers, need to know about this disorder. I will start my presentation with a very interesting case which I saw very recently. This is a case which we see multiple times in our clinic, both in mental health clinics as well as in sleep apnea clinics. This is a 50-year-old white male who came with his wife and came in with complaints of depression. His wife was telling me that he has been depressed for the last 2 years. He has been spending his time at home, not working, has gained a lot of weight. Wife said, "Doctor, I am done with this person. He does not want to do anything. He is always depressed. He cannot sleep well. At times he does not sleep. He is so fatigued that he is useless." The patient, on the other hand, reported that he had diminished ability to think. Well, we said let's do a patient healthcare questionnaire, which is a screening tool used in a lot of primary care clinics. Score of 10 or above is abnormal, and in this patient's case, it was 23, suggestive of severe depression. His medical history was significant that he has high blood pressure and diabetes. He was quite overweight, as you could see from the picture. Well, in that mental health clinic, he was started on Paxil. 4 months later, he came back. His PHQ-9 score was slightly better, but his symptoms of hypersomnia, psychomotor retardation, fatigue did not get any better. Well, once he was sent to our sleep clinic, we asked him about snoring. And wife said, "Doctor, he shakes the house." Wife told us that he stops breathing at night. His neck was quite large and he has already gained more weight being on Paxil. Well, I'm going to show you a normal overnight oximetry, which is a tool which we use to look at whether patient's oxygen saturation is normal during the night time. Now, if you look at this person's oximeter seems normal. This is 90% saturation. Oxygen saturation is remaining above 90%, which is normal. But if you go to see this patient, his oxygen saturation was way below 80, touching 70%. Look at this information. Well, the question I have is that, of course, all the mental health providers, even primary care physicians and providers, know that he has symptoms of depression. But then looking at his oxygen saturation, does he have obstructive sleep apnea? Or does he have both? That is the point I'm going to make in my presentation. Obstructive sleep apnea and depression have very common comorbid overlapping symptoms. If you look at this, these are specific symptoms for obstructive sleep apnea: snoring, witnessed apneas, and snort arousals. Sadness, anhedonia, agitation, guilt, weight loss, these are symptoms of depression. And look at this: daytime sleepiness, fatigue, loss of energy, poor concentration, irritability, which our patient had, psychomotor retardation, and weight gain. These are all symptoms of depression and of obstructive sleep apnea. But I'd like to give an example of obstructive sleep apnea and depression as comorbidity, like an animal, and different disciplines are like blind monks who are trying to examine it. So if somebody is examining the trunk it would describe that as a pipe. But if somebody is examining the big feet, they might feel it's a big pillar. So similarly, in a pulmonary or sleep apnea clinic, if somebody patient like this is seen, they would say the person has obstructive sleep apnea and may not pay attention to the depression. Whereas if this person is seen in a mental health clinic, he would be diagnosed with depression and be treated and may benefit from it, but his sleep apnea might get ignored. So, my agenda today is that I would like to talk about these patients because you are the ones who see these patients and you are at the front head dealing with all these patients. So, we'll talk about obstructive sleep apnea. So, you would learn about obstructive sleep apnea. You will also learn about obstructive sleep apnea and depression's relationship. You learn about prevalence of depression and obstructive sleep apnea. What is the correlation between obstructive sleep apnea and depression? In addition to that, you will also learn what are the possible mechanisms of how obstructive sleep apnea might be causing depression. You would learn if treatment of obstructive sleep apnea has positive effects on mood. And then we'll look at concluding this talk. Okay. So, on the left hand side, you could see a sagittal section of a normal person who does not have obstructive sleep apnea. If you look at it, a person breathes through their nose, air goes in, person breathes through their mouth, goes in behind the tongue into the larynx. So this is a normal airway. Whereas in patients who have obstructive sleep apnea, this area is crowded. So the air comes in, hits this obstruction, swirls around and causes snoring. So this airway is blocked. Looking at this video, so the airway is blocked in patients who have obstructive sleep apnea. Now I'd like to give an example of a tube. Upper airway in humans is like a tube. There are factors which are keeping this airway patent, keeping this airway open. There are factors which are trying to compress this tube and close it. So what are the factors which are trying to keep it open? And what are the factors which are trying to close it? Now, every time a person breathes in, air goes in, and there is a suction which is created which tends to collapse this airway. Similarly, anything from outside like pressure from the tissue, fat, any big neck mass, any issue, fat would be compressing on that. So, what are the factors which keep the airway open? Now, it turns out that every time we breathe in, there is a neuronal mechanism by which the pharyngeal dilator muscle, which is our tongue, gets taut and keeps the airway open. Now, I'd like you to learn about this sleep apnea cycle because when a person stops breathing, because of their airway is collapsed, their oxygen levels start going down, carbon dioxide levels go up, and then their brain arouses and they start breathing again. And this is a cycle which happens repeatedly. But let's look at how this works out. Well, I'd like you to think about a person being in the state of wakefulness or just falling asleep or sleeping. So if you look at it, a person whose upper airway is deficient, that is, they have narrowed airway cavity, it is compensated by high tone of the muscles in neck and the tongue when a person is awake. When they fall asleep, upper airway muscle tone tends to go down. The lung volumes tend to go down. The central respiratory drive tends to go down. When they fall asleep, upper airway collapses. Now, depending on the lung volumes and gas stores, the carbon dioxide levels start going up, oxygen levels start going down. What this does is that it increases the central respiratory drive and the upper airway muscle drive, but this is usually not enough to open the airway. As a result, a person has an arousal, the brain arousal. When they arouse, they're almost in the state of being wakefulness, so they have increased upper airway muscle tone. Their lung volumes go up because they start breathing heavy. ventilatory response goes up. The airway opens up, so they breathe, they hyperventilate, they blow away the carbon dioxide. As a result of that, there is instability in their central drive to breathe, which could lead into another apnea. Now, this is a typical sleep cycle which goes on and on and on throughout the night. Now, I would like to show you a bit of definitions. It will be important for you to know about these definitions. What is apnea? Apnea is when a person stops breathing. What is hypopnea? When a person's breath becomes shallow and it is accompanied by a reduction in oxygen saturation. Apnea Hypopnea Index, AHI, is how we quantify obstructive sleep apnea. This means this is how many times a person either stops breathing or have decrease in oxygen saturation per hour. So if somebody's AHI is 5, it means they stopped breathing 5 times per hour. So between 5 to 14 is considered as mild, 15 to 29 is moderate, and 30 and above is severe sleep apnea. I want to show you how we diagnose patients with obstructive sleep apnea. So this is a picture of a person who's about to go for a sleep study. Now you're not able to see her face, but you can see there are a lot of wires attached. The wires are attached to her head, her eyes, her chin. These records EEG, eye movement, EMG. Then of course she has EKG, and there are channels around her nose which records airflow, channels around her chest and abdomen, and of course pulse oximetry. Okay. I'm going to show you a typical page of a polysomnogram. Now it might seem a bit confusing, but I'd like you to look at this first. I'm going to try to orient you with this page. The things which you see above here, these are EEG brain electrical activity. So this is activities of the eye. This is EMG. This is typical EKG. Now I'm going to show you here. So looking at this channel, this is snoring channel. So a person is breathing in and snoring. So the abdomen is moving out, thorax is moving out, but then here you see there is no airflow. What happens is that the person has stopped breathing. When a person has stopped breathing, there is no airflow going on. When there is no airflow going on, the body is going to try to breathe. So here you see these paradoxical movements. When you see the paradoxical movements of the chest and abdomen, it means that their upper airway is obstructive and the body is trying to breathe. But then, as a result of that, the person has a brain arousal and then they start breathing again. But as a result, when they have stopped breathing, the oxygen saturation has gone down. I'm going to try to show you a video of obstructive sleep apnea. Well, I want to talk about how mild snoring, severe sleep apnea is related. The person is breathing quietly, sometimes they have intermittent snoring. So it's a continuum. The severity is a continuum. So somebody who has some snoring, it means there is some mild upper airway blockage, but not to a point where it's disturbing. Now, upper airway resistance syndrome is when snoring is disturbing the sleeping. So as you can see, it's a continuum from snoring to severe sleep apnea. What's the treatment for sleep apnea? CPAP stands for continuous positive airway pressure. It's the main first line treatment for sleep apnea. PAP therapies are divided into different categories, but for us, we want to know the two simple ones, which is CPAP, continuous positive airway pressure, or APAP, which means automated airway pressure. The difference between the two is that CPAP has one pressure setup set 8 centimeters or 9 centimeters of water, Whereas in APAP, the pressure ranges are set up, say, between 10 to 15, and the pressure changes between that depending on the position. So if a person is sleeping on their back, they might need more pressure. These are different masks. As you can see, there are some nasal masks. These are nasal masks, some mouth. This is a full face mask, different varieties of masks. I want to show you an hypnogram, which is a graphical picture of the whole night study. This is the first part of the hypnogram when a person is not being put on sleep apnea. For this person, if you look at the top here, these are the different stages of sleep, but you can see the person is going back and forth from stage 1 to wakefulness. Look at how fragmented the sleep is. This person is in supine position. This is obstructive apnea, looking how many obstructive sleep apnea a person is having. This is overnight oximetry channel, so it shows us how bad the oxygen saturation has been. Now this is the first portion of the night. The person has not been put on sleep apnea CPAP machine at this time. But let's see what happens. Person is put on CPAP. Looking at the pressure of the CPAP is going up. Here the sleep starts becoming more consolidated. You can see going into stage REM. Looking at the oxygen saturation, just compare this to this. The oxygen saturation becomes normal. This is a normal occurrence we see in a lot of patients who go through sleep studies and have sleep apnea. What are the other devices? Use dental devices. What this device does is it brings the lower jaw forward. So the tongue is pulled forward. As a result, the space at the back is opened up. This is a tongue retaining device. It's a bit awkward. The tongue is stuck in here, has some side effects, but it is pretty effective. So I would like to go over what are the risk factors of obstructive sleep apnea. So who are the patients in your population, in your clinic, patients you see on a daily basis who could be more at risk for obstructive sleep apnea? So somebody who tells you that they snore, somebody who is overweight. Looking at this gentleman's neck circumference, it's huge. Looking at his BMI, it's huge. Pharyngeal abnormalities. The wife says witnessed apneas. These are risk factors. Now, you can also do an oral cavity exam. Now, I know a lot of mental health providers do not want to touch patients, and you do not have to. You can just ask them to stick their tongue out. If you can see this whole structure and the tonsils, this is adequate airway. Here you could see partial. Here you cannot see anything. So this is Mallampati 4. You could also use Epworth sleepiness scale, which you can download from internet. It's free. And if the score of this questionnaire is 9 and above, a person is deemed sleepy. Now this is a subjective scale. Has to be taken with a grain of salt. Now, this is a very important slide for mental health providers as well as for all other medical providers. Snoring and obstructive sleep apnea is just the tip of the iceberg. What is underneath it? Several things. For example, we know that sleep apnea is highly prevalent. It is like diabetes, which is there in the community and it takes some time before it's diagnosed. The healthcare cost is humongous. There was a study out of Canada suggesting that patients who have obstructive sleep apnea, prior to being diagnosed with obstructive sleep apnea, looking back for 10 years, their medical healthcare cost is twice the cost of patients who are similar and do not have obstructive sleep apnea. Wisconsin Cohort study suggested that cardiovascular risk goes up in these patients 3 times. All-cause mortality 3 times. So, we have talked about obstructive sleep apnea. We have talked about general introduction to obstructive sleep apnea. Let's look at, for mental health providers, why it is important. Is there a relationship between obstructive sleep apnea and depression? So, let's talk about whether there is increased prevalence of depression in patients who have obstructive sleep apnea. Looking at the population and community samples, different studies, 20,000 adults from 5 European studies. Out of 857 patients identified as having obstructive sleep apnea, 17% had depression. In non-obstructive sleep apnea group, only 44.3 had depression. So the odds ratio of sleep disordered breathing in patients with MDD is 5. So the 5 times more risk of having sleep disordered breathing. Looking at another study from Houston, more than 100,000 veterans' records were reviewed. Majority of the patients who have obstructive sleep apnea had depression. The prevalence was more than 20% as compared to the ones who do not have obstructive sleep apnea. Now, in clinical sample, it's a little bit biased, but that's what you see. If you look at this Dutch sample study, uh, 41% had depression, 30% had depression. So these numbers are quite high. Now, it is difficult to establish whether there is a correlation between obstructive sleep apnea and depression. So, if the two disorders are present in the same person, it does not necessarily mean that one is causing the other. There have been some studies. For example, this study was a prospective study in which more than 1,400 patients were enrolled. They were followed with polysomnograms, and the risk for depression was twice every 4 years when they developed depression, obstructive sleep apnea. Now, going into possible mechanism. Now, if we think that there might be a relationship, what are the possible mechanisms? We have, as scientists, we have to know what are the possible mechanisms. So, looking at this, if you look at, so many disorders can cause excessive daytime sleepiness. Obstructive sleep apnea, depression, sleep disorders, OSA. So how we differentiate? Now we look at this relationship between depression and obstructive sleep apnea. We look at serotonin. We know that serotonin has something to do with depression. Now we're also finding out that there is reduction of serotonin input to the upper airway dilator muscle, which is our tongue, in patients who have obstructive sleep apnea. We know that the inflammatory markers are elevated both in depression and in obstructive sleep apnea. We know that there could be genetic factors, obesity could play a role. In addition to that, sometimes the drugs could play a role, but we did not talk about the relationship with depression, cardiovascular disease, and depression and cardiovascular disease and obstructive sleep apnea. Now, if you look at biopsychosocially, obstructive sleep apnea and depression might have shared pathway, but then both disorders can cause sleepiness, cognitive problems, and fatigue. As a result, people can have poor performance, social isolation, which could lead to depression or worsening of depression. Somebody who's depressed, he or she is going to get more inactive, maybe gain more weight, and have more severity of sleep apnea. So it's a vicious cycle. Now, do we think treatment of obstructive sleep apnea helps? We know that it helps with the quality of life. There are different ads suggesting that obstructive sleep apnea could treat daytime fatigue and depression, and there might be some truth to it. But going forward, looking at this study of 50 individuals, their baseline Beck depression inventory, they looked at that. The Beck depression inventory went down after they were treated for sleep apnea. Sustained improvement with CPAP use. With residual symptoms of depression, 17 patients, residual symptoms, BDI, Hamilton depression ratings decreased from 19 to 10, 16 to 8 after 2 months of CPAP therapy. Now, granted that their numbers could have gone down because of feelings of more alertness, sleepiness would have been better. So, looking at this study, 4 out of the 7 studies showed that there is improvement. There was a clinical review of CPAP and behavioral therapies in patients with obstructive sleep apnea, effects on daytime sleepiness, mood, and cognition. They included randomized clinical trials. Comparison was oral sham CPAP. 5 of the 7 studies showed improvement. So, I will conclude that obstructive sleep apnea and depression are very common comorbid disorders and they have a very complex relationship. For psychiatrists, mental health providers, therapists, psychologists, it's really important to screen for patients when they're seeing them in their clinics for depression. We know that rates of depression are really high in obstructive sleep apnea. Both disorders should be screened when evaluating depression or OSA. Treatment of OSA may improve depressive symptoms in patients with comorbid depression and OSA. Now we need further research, but I would conclude that anybody who is seen in the clinic should be for depression should be screened for obstructive sleep apnea and vice versa. Thank you.